I'm going to introduce our first speaker, Susanna Fenstermacher, and Susanna is a pediatric nurse practitioner at Seattle Children's Hospital in the Division of Neurology, where she specializes in the care of children and young adults with epilepsy. She cares for patients in both inpatient and outpatient settings with initial testing and diagnosis of epilepsy through management of refractory epilepsy. Her clinical subspecialties within the epilepsy program at Seattle Children's include dietary therapy, neuromodulation, and the care of patients with tuberous sclerosis complex. She has been the medical director of the Epilepsy Foundation Washington's Camp Discovery for the past 2 years and is a member of the Epilepsy Foundation Washington's Professional Advisory Board as well. She has a passion for outreach and education and is honored to be able to join you today. Please welcome Susanna.
Good morning. So as Kevin said, my name is Susanna Fenstermacher. I'm a pediatric NP at Children's in the epilepsy department. So I was asked to give kind of an Epilepsy 101 talk this morning. And as many of you know, that could be this whole conference. So I'm going to try to do some quick overview of some topics that might be of interest. I'll try to leave some time for questions. We have a great panel at the end of the day as well for more questions. But I wanted to touch on just some topics that are applicable to our pediatric patients, to our adult patients, and everybody that is living with epilepsy or cares for somebody who is living with epilepsy. So, topics for today that I'm going to touch on. We'll touch a little bit on seizure basics and describing seizures. There's been some changes in how we talk about seizures and the terms that we use, and depending on when you received a diagnosis or first heard about epilepsy, these terms might have changed. And so I just wanted to make sure that we are all on the same page with how we talk about seizures and what that looks like. I want to talk a little bit about the definition of epilepsy that your epilepsy providers use, and the pathogenesis of epilepsy. Again, that could be a whole talk, so we'll just talk about kind of the areas of research. We'll talk a little bit about the diagnosis of epilepsy, some of the major tests that we use, and what they can and cannot show us. We'll talk a little bit about treatment of epilepsy and some of the more recent things that we use in the treatment of epilepsy. And then I wanted to finish just with a few notes about communicating with your epilepsy team, because this is really this is a partnership. This is something that we work together on. And so being able to effectively communicate back and forth is really key to providing the best care and for the best outcomes. So I wanted to talk about that as well. So starting off, seizure basics. We're going really basic. What is a seizure, right? So neurons are your brain cells, and they communicate using electrical signals called action potentials. And these signals determine how they release neurotransmitters, which allow them to talk to other neurons and carry on those electrical signals, right? And this is happening in your brain all day, every day. Neurons are connected in elaborate networks, right? They don't act independently, they're in networks. So one neuron or a small group of neurons can really influence a much larger group quite quickly. And so when a seizure happens, electrically what's happening is that there's a malfunction in this signaling. And this causes the neurons to have this sustained, rapid signaling. And this spreads across neuronal networks, and this is where you get what we call an electrographic seizure, an electrical seizure. And often that becomes a clinical seizure. And that is the transient occurrence of signs or symptoms, and that can be a whole list of things, due to this abnormal synchronous neuronal activity, right? And I have this graphic here from the Cleveland Clinic, which I thought I like metaphors, I like visualizing, and so I found this helpful. If you think of these neurons like roads and traffic lights, right? You have stop, you have go, you have all this activity going through. These networks connect the different parts of your brain. They connect the towns, they connect the neighborhoods, right? And so seizures happen when the traffic lights short circuit and the order that's typically in those networks is taken away, right? And the more neurons, the more traffic lights, as you know, that go haywire, the more concern we have, right? And the more widespread the symptoms or the seizure is, okay? So thinking about how do we classify seizures? So many of you may have heard the terms grand mal, petit mal, partial seizures, but we've stopped using these terms. And the reason for that is that they don't really tell us what's going on. We really like to describe things in a way that shows us what the clinical and the electrical activity is, because that's how we think about treating it, right? And so our two broad classifications that we use right now are focal seizures and generalized seizures. These are the two big umbrella terms, right? So focal seizures are seizures that start in one side of the brain, one hemisphere, right? And this can be a very small area. This can be the whole hemisphere, but it's only one side. Generalized seizures start in both sides of the brain at the same time, okay? And as we know, focal seizures may become generalized, right, as they spread, as those neuronal networks involve other networks, but they don't have to, right? Generalized seizures already involve both sides of the brain, okay? And so this is the classification of seizure types from the International League Against Epilepsy, which is, I like to think of them as a superhero organization. It sounds very superhero-y. But they do a lot of work with making sure that the terms we use make sense to patients and providers alike. And so this is the classification. So we see focal onset, we see generalized onset. I don't know, do I have a pointer? Oh, there we go. So you see focal onset, you see generalized onset, and sometimes we don't know the onset, right? That's often one of the big questions, is figuring that out. And then within each of these categories, you have the classification of aware or impaired awareness, right? And with generalized seizures, we're impacting as enough neuronal networks that we have impaired awareness. That's one of the characteristics, right? But with focal seizures, we may be involving a small enough piece of the brain, of the neuronal networks, that we have some retained awareness. And some of you may have experienced that. And that's really important when thinking about how we can best treat, right? And then within each of those categories, we further classify it down to motor. Does it involve movement or non-motor seizures, right? So these are terms that you may be hearing, and so I wanted to make sure we were all on the same page with what those meant, because they matter for how we treat seizures. So then we think about, okay, there are a bunch of other terms that you may have heard that we use to classify the clinical symptoms of seizures. And in medicine, we have so many terms that I always like to know where the terms come from, because it helps me remember what they're describing, right? So tonic seizures involve increased tone, from a Greek root tonikos, meaning stiffening, right? So increased tone, tonic, tone. Clonic means rhythmic jerking, from klonos, meaning agitation, right? So therefore, a tonic-clonic seizure, as we may have heard referred to as grand mal before, right, a generalized tonic-clonic seizure, is stiffening followed by rhythmic jerking, tonic-clonic, right? So then if tonic is increased tone, atonic, right, A is the opposite, right, lacking tone, right? So this is where we get seizures that we might call drop seizures, right, when they involve a large portion of the body. So if clonic is rhythmic jerking, myo, we know, is the root for muscle. So myoclonic seizures are brief little shock muscle jerks, right? So these terms start to make sense when we think about how they're put together, but I know they can feel foreign because we don't really have other terms that we use for them outside of talking about seizures. A quick note on epileptic spasms, right? We sometimes call these infantile spasms when they occur in our youngest patients. This is flexion and or extension of the muscles in the head, arms, or legs. This is a specific type of seizure. So we want to be careful when we're calling something a spasm. In the general vernacular, we use the word spasm to mean a lot of different things. And when we're talking about seizures, it's very specific. So I just wanted to highlight that. And then absence, we call them absence, right? Because a lot of the classification is in French, right? Absence, very fancy. You can think of it as absence, right? This is a behavioral arrest. This is staring. This is what used to be referred to as petit mal, right? And you'll see that the grand mal and petit mal, both of these types of seizures are generally generalized seizures. And so grand mal and petit mal doesn't tell us anything about where they start, what they look like. And so these terms allow us to be much more specific. Okay. And then I didn't go into focal seizures here because there's so many different symptoms and so many things that we can have under focal seizures, but that's what we would used to call partial seizures, right? Which makes sense. It's a part of the brain, but focal's a little bit more specific. Does that make sense? I haven't lost you yet? Okay, good. So I wanted to just move in from talking about seizures to talking about epilepsy and how we define that and what that means, right? So the clinical definition that your providers are using is again from that superhero organization, the ILAE. And epilepsy is defined as a disease of the brain by any of the following conditions. So there's 3 things that can give a person that diagnosis. One of those is at least 2 unprovoked or reflex seizures occurring more than 24 hours apart. So if the first seizures occur within 24 hours, we tend to classify that as kind of one event, right, in terms of diagnosing epilepsy. So they need to occur more than 24 hours apart. And unprovoked means that there's not another clinical reason that we know that these are occurring. Say if somebody had a traumatic injury or something like that, right? The other definition that we often use is a little more tricky, and that's one unprovoked or reflex seizure and a probability of further seizures similar to the general recurrence risk, so at least 60% after 2 unprovoked seizures over the next 10 years. And so what this really refers to is a lowering of the seizure threshold, right? Everybody has a seizure threshold where if you have enough activity over that, anybody can have a seizure. But what epilepsy really refers to is that seizure threshold is lower for some pathologic reason, right? And we're going to talk a little bit about why that happens. This is often represented as an abnormal EEG, right, which is something that many of you may be familiar with. This demonstrates an ongoing risk for seizures, right? And that tells us that seizure threshold is lower at baseline, okay? And then we also have a diagnosis of an epilepsy syndrome. And so there are syndromes, right, that are suggestive that seizures are very likely. And so this can be part of that diagnosis. One of the new additions to kind of this definition is, when do we consider epilepsy resolved, right? And I want to differentiate that from cured, and those are complicated terms. But epilepsy is considered to be resolved for individuals with an age-dependent epilepsy syndrome, so some of our pediatric patients, but are now past the applicable age, right? They're not having seizures, they're past the age where we would anticipate that they have seizures in that age-related syndrome. Or those who have remained seizure-free for the last 10 years with no seizure medicines in the last 5 years. Epilepsy is considered resolved. We would say you have a history of it, right? And as we know, this is a very technical clinical definition about seizures, but epilepsy, importantly, is also characterized by the neurobiological, the cognitive, the psychological, the social consequences of having seizures and the ongoing predisposition to having seizures. And those impacts are really important and influence significantly how we treat, right? Oh, I have a clicker, excellent. So thinking a little bit about how epilepsy develops. So in general, there are kind of 3 main mechanisms, as we see over on the left-hand side there, for what happens in epilepsy. We have too much excitation, leading to that prolonged depolarization. We have too little inhibition, right? We're not putting on the brakes enough, and we get that. And there's too much crosstalk. There's abnormal signaling across networks, right? And so this is a big area of research right now, is figuring out how epilepsy develops and why, and how we can work with that and treat that. And so these are some of the ways that we think, some of the pathways that may be influenced in the development of epilepsy. And all of these are areas of really specific research right now. And how is this something that we can change before it becomes clinical? Okay, so moving a little bit into the diagnosis of epilepsy, right? So we already talked about the definition. What else do we do when we're thinking about diagnosing epilepsy at the beginning of that journey? So I have here a couple of clinical tests, and I call these the clinical puzzle pieces, because really what we're doing is we're putting together a clinical picture, right? And all of these tests combined with your experience, with the patient's experience, with what seizures look like clinically, this puts together a picture, and then we do our best to treat the picture with what we know. And this picture is continually evolving, right? Things change, and so this picture changes. And so sometimes we need to repeat these tests as things change. So one of the most common tests that I'm sure many of you are familiar with is the EEG, right, the electroencephalogram. And this is recording electrical activity of neuronal networks. So we're putting electrodes on the scalp, we're recording the electrical activity to tell us whether there's risk for seizure, and that's often termed interictal epileptiform discharges, which just means interictal is just between seizures. Epileptiform refers to the potential to have epileptic seizures. So seizures between risk, right? Risk between seizures. Whether events are captured are seizures and where they start. And I put an asterisk here because this can be a little bit tricky. As we talked about with focal seizures, they can often involve a very small section of the brain. And the epileptologists that I work with, I forget the first time I heard this, but this is the analogy I always use because again, I like metaphors, it makes sense to me, is that imagine you're fishing from the top of a lake, right? That's what an EEG is. A scalp EEG is we're fishing from the top of the lake. And there may be a fish down at the very bottom of the lake, very deep in the lake, and all we may see from that fish are ripples on the surface. We may not see that fish, right? And so if the fish is very close to the surface, we might get a really good sense of where that fish is and how we can localize it. But sometimes that fish is harder to see. It's deeper down. And so EEG is limited in its capability. Scalp EEG is limited in its capability because of the distance, right? We're going to get better signaling from things that are closer to the surface. So a little asterisk there. And also whether background electrical activity is normal. Sometimes we talk about things like slowing on EEG, which they can be kind of non-specific findings, but they do tell us that there's something in those neuronal networks that's abnormal, and that can often point us to localization of seizures, right? Unfortunately, what an EEG does not tell us is whether somebody will have a future seizure or not, right? An EEG is a snapshot. It shows us a picture in time of what somebody's risk looks like, and we extrapolate that across somebody's days and weeks. But it doesn't tell us for sure what's going to happen. It doesn't tell us whether a past event was a seizure, right? An EEG is a test that a lot of people get after they've had something clinically concerning for a seizure. But it doesn't tell us what that past event was, and that's where that clinical picture really comes into play, and where the expertise of your neurology or epilepsy provider comes into play. Was that clinically concerning for a seizure? Does that match EEG findings, and where do we go from there? It also doesn't tell us exactly how high the future risk for seizure is. So we can get a sense if the abnormal discharges are really frequent, we can say this is a higher risk. If the abnormal discharges are occasional, we can say this is a lower risk. But that doesn't necessarily correlate exactly to how likely it is that somebody will have a seizure. If you have that risk is there, right? So then thinking about some of our imaging studies, the two common ones that we use are MRI and PET scan. And I want to differentiate these a little bit because I think sometimes they get kind of put together. So the MRI gives us detailed pictures of the brain's structure, right? And this is looking for whether there's structural abnormalities that might be related to seizures. This can be something like a tumor. This can be something like what we call a dysplasia, which is a very small area of tissue that didn't quite develop correctly as a person was growing. And so this really is looking for, is there anything structural that we might want to take a closer look at that might be implicated here? And then again, does that match what's happening clinically? We always go back to what you or what the patient is experiencing clinically. And does it match, right? Unfortunately, the MRI doesn't tell us whether the structural abnormality is causing seizures, if there is one, right? And so that's where we're combining it with the EEG to say, is this in the same place? And what does that mean? So then we look at the PET scan. And the PET scan is where we get what I in pediatrics call the rainbow pictures of our brain, right? And this is looking at metabolism. And so we use a radioactive tracer that's attached to sugar. The brain really likes to use sugar, and so sugar travels up into the brain starts using it, and then we take pictures as it's using that radioactive tracer. And we see what areas are more active, what areas are less active, and does it look the same side to side, right? One of the things that we're always comparing is, does one side look the same as the other side? Because if not, which one is abnormal, and what does that mean for where seizures might be coming from? And on the PET scan, we're really looking at that in color, right? So I know this is a tiny picture. Hopefully it'll be bigger in the recording. But red, warmer colors are increased areas of metabolism. Cooler colors are lower areas of metabolism. And you can imagine that in kind of a normal state, a brain that's not having a seizure, areas that are cooler might indicate dysfunction, might indicate that those networks aren't working the way we would anticipate them to. And that can be a sign that that might be an area where we want to look for seizures starting. You can imagine that if somebody happens to have a seizure during a PET scan, their PET scan looks very different, right? Because there's so much extra activity that can be confounding. And so this is a test that we really want to see at baseline, right? Because then things can change. Okay. One of the other big pieces for diagnosis, especially now, is genetic testing. And we're going to have a wonderful talk from Fuki this afternoon, who's truly the expert. And so I just wanted to kind of talk about the initial steps here. So many epilepsy syndromes are thought to have a genetic predisposition, even epilepsy syndromes that we once called idiopathic, which is a clinical term for we're not sure, right? We don't know where they're coming from or why. And so if there's not a clear structural cause for somebody's seizures, we start thinking about genetic causes. And so some of the tests that we use are listed here. But as you can see in those 2024 recommendations from the National Society of Genetic Counselors, we are moving more and more towards whole exome, whole genome, large gene panels. And so what's really important here is that if somebody has had genetic testing even a couple of years ago, things have likely changed, and it might be something to think about reconsidering. This is something that we look at on the order of every couple of years. We're always discovering new genes that are involved. We're always discovering new techniques. And so this is something that we reassess, right? Just like we might repeat an EEG, this is something that we reassess, and it's part of that clinical picture. Okay? So something important to think about, even if diagnosis was quite a while ago. Because things might have changed, we may have more of an understanding. And this helps us guide medication choices. In the future, this may help us guide targeted therapies. So this can really be helpful in thinking about next steps. Okay, so now thinking about how do we treat epilepsy, and just an overview of that, some pieces to think about. So medications, right? These are our first steps. And I just wanted to talk a little bit about how anti-seizure medications work, because I think often the clinical conversation is, okay, we're going to try this medicine, we're going to try that medicine, here are the side effects, and these are the things. And I find that it's helpful to know why your epilepsy providers are thinking about what they're thinking about and talking to you about in terms of medicines. So as we talked about before in thinking about how seizures happen and how epilepsy develops, anti-seizure medications have two primary mechanisms of action. We're either decreasing that excitation, that's too much, or we're increasing inhibition, we're putting on the brakes, right? And within those mechanisms, there's a lot of different places where the medications can act. So this diagram over here is one of my favorites. Anybody in my division will tell you that every presentation I get has to have this diagram in it, because I think it's such an interesting representation of what happens. And I don't want to focus on the specifics today. This is what we call the synapse. This is the area where two neurons are talking to each other, right, are communicating. And so these little dots here are the neurotransmitters. This is the neuron that's sending the signal. This is the neuron down here that's receiving the signal, right? And so you can see in the blue here, these are all different anti-seizure medicines that some of you may be familiar with. And you can see all the different places that they're acting in that synapse. And a lot of these medicines have multiple mechanisms. So they're not only acting on, say, a sodium channel, but they're also acting on calcium channels, or they're also acting on potassium channels. And that can be really important for both the treatment of seizures, but also the experience of the person taking the medications. And so this is something we really want to think about when we're choosing our medicines, because multiple medications of the same mechanism of action, the same primary mechanism, can increase the person's risk for side effects, right? Because we're acting on the same place. And so a lot of those side effect profiles look really similar. And so if we add 2 medicines or 3 medicines that all work on the same place, we may get more of those side effects. Similarly, if we have a drug that works on, say, I'm going to pick on the sodium channel because we have so many drugs there. If we're using a drug that works on, say, the sodium channels to help prevent seizures, and it really works for you, but those side effects just make it intolerable, make it something that you just can't take, we may choose another medicine in that list that says, okay, this works a little bit differently, but it works in the same place, and we know that place works, but this might have side effects that are more tolerable or no side effects for you, right? We know that some medicines are what we call synergistic. They work together, and that may increase their drug levels. And so that's really important when choosing medicines, that we know what you're already taking and how that worked for you. And this is where experience and that communication is so important. We also know that if there's a genetic change, and this is going back to where that genetic diagnosis is so important, in a specific channel, say the sodium channel is a common one, we may avoid drugs that act there because they're not going to have the effect that we want, right? So this is really the basis of how we're thinking about what medicines we suggest. But I suggest that this is also the basis that you think about how you're experiencing your medicines and your side effects, and how you talk with your epilepsy provider about it. And say, you know, this drug really worked for me, but I just can't handle the side effects, which happens a lot. Can we switch to something else that works in the same place? Or I think these 2 drugs, when I take these 2, they seem to have this major side effect. Could we switch one of them to maybe reduce that? So that can be an important piece in thinking about how we choose medicines, because we have a lot of options, as you can see. Speaking of all of our different options, I just wanted to throw this in here in thinking about the development of anti-seizure medicines, because we're always thinking about what's next, right? What's new. And you can see that we've had just an explosion of the different kinds of anti-seizure medicines since, starting back in the 1930s and onwards. And so we're always trying to refine how these medicines work, their side effect profiles for the best options. And so in the last 3 decades, even, in the last few years, we've had a few more. And so I wanted to just talk about those briefly, because they're names you may have heard of. So, our newest anti-seizure medicines. So, vigabatrin's not a new medicine. It's been around for a long time. We use it to treat primarily infantile spasms. Recently, we're very excited that there's a new prepared solution. So, if you have used the powder that you mix, there's a new prepared solution for our infant patients, which is very exciting. Fenfluramine was approved in 2020 for the treatment of Dravet and Lennox-Gastaut syndromes in patients over 2 years old, so 2 years old and up into adulthood. We have cenobamate, which is approved in the U.S. for focal onset seizures in patients greater than 18 years old. We are starting to use this in our pediatric patients as well, specifically for focal seizures. Everolimus, this is a treatment that's used in a lot of different indications, and it was approved in 2018 for the treatment of focal seizures in TSC, or tuberous sclerosis complex. So this is a very exciting development. This is something that we can use in TSC for treating overgrowth as well as seizures, so that can be a helpful mechanism. Steripental, again approved for Dravet. This is in combination with clobazam or ARNP in pediatric patients over 6 months that weigh 15 pounds up into adulthood. This was approved in 2018. The age was just lowered a few years ago. So now we can use this in our younger patients. And then Epidiolex, CBD, this is one that's been all over, I think. This was approved in 2018 and more recently in 2020 for patients with TSC. This is approved in Dravet and Lennox-Gastaut syndrome, but we sometimes think about using this in other severe epilepsies as well. A word of caution, we can, obviously cannabidiol is available in public. The reason that your neurology or epilepsy provider will often talk to you about Epidiolex specifically, is that we know exactly the components of it. It's a medicine, and so we know exactly the components, and so we're able to prescribe it in a dose like we do all of our other pharmaceuticals, and that limits variability, which can impact seizures. And so I just wanted to take a quick note on that, since I know this is also available in the community. Okay, so I wanted to talk about when medicines fail, because medicines don't always work, as we know. And so what other things do we think about? So just general statistics, about 50% of patients will become seizure-free with their first well-chosen anti-seizure medicine. And well-chosen is key there. That's where we really want to think about those mechanisms of action and which is going to be best. Another 14% of people that are not seizure-free with their first become seizure-free with their second. So we have about a quarter of folks, right, maybe more, a little bit more, where we've tried 2 medicines and we haven't achieved seizure control. And so we start thinking about other options as well as different medicines, right? Because we know that after that point, the likelihood of each subsequent medicine working completely goes down. It may help, but we want to think about other options. And so this is where we think about things like epilepsy surgeries. We think about resection, which is removing. We think about laser ablation, which is destroying or zapping. We think about hemispherectomy, which is disconnecting the 2 sides of the brain, right? We also think about neuromodulation devices. We think about the vagus nerve stimulator. We think about the responsive neurostimulator, and we think about the deep brain stimulator, right, as listed there. We'll talk a little bit more about each of these. And then we think about dietary therapy, right? We think about the ketogenic or modified Atkins diet and whether that's an appropriate choice. So I want to touch on just each of these a little bit. So epilepsy surgery, right? Epilepsy surgery is indicated in about 30 to 40% of patients with what we call refractory epilepsy. So this is somebody who continues to have seizures even though they've had an appropriate trial of 2 anti-seizure medicines, and research is actually coming out that's showing us that this might go down to 1 seizure medicine. We may want to start thinking, if we think there might be a structural cause, we may want to start thinking about this earlier than even 2 medicines, right? And so when we think about epilepsy surgery, we have a 3-phase approach to the process. We think about a phase 1, and some of you may be familiar with the phase 1 admission, right? You come into the epilepsy monitoring unit, we call it a phase 1. This is our first step in thinking about epilepsy surgery. And really the goal here is that we want to capture seizures on the EEG in our epilepsy monitoring unit, or the EMU, to figure out where they're coming from. And again, remember, this is scalp EEG, so this is that looking for the fish in the lake, right? And so sometimes we're able to see, oh, yep, looks like it's coming from this area right there. That looks good. That matches the MRI. That matches the PET scan. This is all lining up. But often it doesn't, right? In that phase 1, we may also consider neuropsychological testing. We may consider fMRI, which is where we have somebody perform tasks during the MRI to look at where certain functions of the brain localize. And that can be really important if we're thinking about, is this an area of the brain that we could remove with minimal deficits for the person, while also potentially taking away their seizures. And so we want to know where those vital components are, where language, where movement is, so that we're not implicating those any more than we would have to, and that we can communicate with you about exactly what that risk looks like. But often, like I said, we're not able to necessarily see exactly where that fish is. And when I've talked with our epilepsy surgeons, our neurosurgeons about this, they tell me that they want to know not just the house in the neighborhood, they want to know the chair in the room, in the house, in the city. They want to know exactly where things are coming from so that we can minimize risk as much as possible. And we do too. And so that's where the phase 2 comes in. And this is where we think about surgical EEG. So this is intracranial EEG, and this is allowing us to get closer to that fish in the bottom of the lake. These are electrodes that are in or on top of the surface of the brain. So stereo EEG or SEEG, these are long, thin electrodes that we place into the brain through small holes in the skull. This is often done with the help of robotics for really precise placement and avoidance of vessels and things like that. This is really helpful for capturing those deep onset zones, right? Because we can record from deep in the brain, not just on the surface. We also use what we call a grid. So this is a grid, a flat grid or strip of electrodes that we place directly on the surface of the brain, and then we can record there. So we're minimizing that skull distance. We're taking that away, and we're recording just from the surface of the brain, and that can be helpful. And then the phase 3 is if it's indicated surgery. And so I know at Seattle Children's, we have what we call an epilepsy surgery conference, where we have a meeting of our epileptologists, our neurosurgeons, our neuropsychologists, our nurse practitioners, our nurses, everybody that's been involved in the clinical care of a particular patient. And we go through that clinical picture that I talked about. We go through, what does seizures look like? We go through, what does imaging look like? What does the EEG findings look like? All of those different things, and we put together what we think are our recommendations. And then the most important conversation happens, which is with you, the patient. And we say, this is what we're thinking might help. What do you think? How does this impact your life? How can we move forward with this together? What do you think about that? And sometimes we say, okay, we found the onset zone, but this is in an area of language, or this is in an area where we can't safely resect, or we can't safely use laser. And then we start to think about potentially other surgeries. And one of the things that you may have a conversation about at that time is neuromodulation. This is one of our newest areas, especially in pediatrics, but in the adult side as well. So neuromodulation devices are these 3 devices there on the right-hand side, and these are devices that deliver chronic electric stimulation to alter brain activity and modulate your neuronal networks, right? Neuromodulation, to change neuronal networks, to change over time that activity to reduce potential for seizures. And so they all work in different ways. Again, this could be a whole talk, but they typically are indicated for generalized seizures, right, that don't have a specific focus that we can think about resecting, that aren't responsive to medicine. They can also be indicated for focal seizures, so seizures that start in one side of the brain, but that might have multiple zones, that might not all come from one specific spot that we can say, yes, that's the spot. We might have multiple spots, or in a zone that we're not able to surgically remove or act on because it's dangerous, right? And so these can be really good options for folks for whom those aren't options. We know that neuromodulation is a long-term therapy, right? And so we can see, this is from one of the seminal studies of how the different neuromodulation devices work. We can see the VNS, the RNS, and the DBS. DBS is the dark circles, RNS is the light circles, and VNS are either the plus, the cross, or the filled-in diamond. But really what I want to illustrate here is not necessarily the different devices, but that this is over years. This is an 8-year time scale on the bottom. And so these are devices that we know with medicines, sometimes we see what we call a honeymoon effect, right? Where you start a medicine and it works really well for 3 months, 6 months, and then it starts to not work as well anymore. And we know that with neuromodulation devices, the chances that they are going to continue to help with seizures over time, over years, are much higher. And this can be something that is very appealing. The other thing about neuromodulation devices is that the surgeries involved tend to be with more minimal risks. There are still risks, of course. This is a surgical implantation of a device. And the VNS in particular, up here, does not involve intracranial surgery. And that can be an option for some folks for whom that's a big concern. So this is certainly something else that we think about. And then one of the other things that we think about, and this is, as Kevin mentioned, one of the areas close to my heart is dietary therapy. And so these are therapies like the ketogenic diet, the modified Atkins diet, the LGIT or legit diet, and the MCT diet. At Seattle Children's, we practice primarily the ketogenic diet and modified Atkins diet, but I wanted to list some others that you may hear of. These are diets that are comprised of low carbohydrate, very high fat, and adequate protein. And I put just some of the history there because I think it's interesting. These diets were referenced very early on, that fasting for seizures, right? Because these diets, what they're doing is they're mimicking a state of fasting without starving a person. And that was mentioned very early on as a treatment for seizures. And so in the 1920s at the Mayo Clinic, the first ketogenic diet, like what we use today, and those are some kind of example numbers, right, was described. But then, as you remember that diagram, phosphenotoin was discovered in the 1930s, and everyone said, oh, taking a medicine is way easier, so we're going to focus on that, right? And there was this big boom of seizure medicines, and so the ketogenic diet or dietary therapies kind of fell out of fashion. But we're starting to use them more and more. On dietary therapy, if it's a well-chosen therapy, about 50% of patients have a roughly 50% reduction in seizures, and another third will have more than that. So this can be something that can be very helpful. This is strongly influenced by the epilepsy syndrome, the types of seizures, and the adherence to the diet, right? This is a tricky type of therapy, but it can be helpful. When we consider this, so this is in refractory epilepsy, so failure of 2 or more medicines, like we've talked about with surgery. This is especially if somebody's not a surgical candidate, this can still be an option for them. And I've listed out some of the syndromes that we think about as prime candidates for the diet, people for whom we know this is really likely to work. But we think about it over a range of seizures and epilepsy. And it can be helpful. But like I said, it's tricky. Unlike many of the therapies that I've talked about today, maybe with the exception of cannabidiol, dietary therapy is something that people think about at home, right? This is something that's accessible without a provider. And I just want to throw in a word of caution because I've seen some negative consequences. The mainstream ketogenic diet you may be hearing about for weight loss or other wellness benefits or things like that, it is not the same as the restrictive diet that we use for the treatment of epilepsy, and it's importantly not the same. The high-fat, low-carbohydrate diets that are used for epilepsy are not nutritionally complete. They require really specific monitoring to make sure that we're minimizing risks of any adverse effects. This is a systemic treatment, right? We're changing the metabolism of the body, and we don't want to take that lightly. And so this is something that really requires the monitoring of a specific team. And I've put some of the side effects there, and that's not to say these are all things that happen to everybody with this therapy, because that's not true. But this is to encourage you, please consult with your neurology provider, your epilepsy provider. This can be a really wonderful therapy when it's managed appropriately and we're able to make sure that the person that's following it is safe. This is not something we'd recommend trying at home, okay, without monitoring. And I put this up here because when you type ketogenic diet into Google, you get these pictures on the left, which look really great. When you think about what it actually looks like for somebody who's eating by mouth, and this is something that we can do for somebody who takes their nutrition through a G-tube as well, the ratios look very different. We can certainly include a lot of the foods that are shown here on the left, but if you think about the amount of carbohydrates that we're talking about, it's the equivalent of basically a small apple a day. And so this is not truly representative, and I don't want anybody to have misinformation. That being said, it can be an excellent therapy, and so if you're interested in it, talk to your providers about it. We're happy to talk to you about it. Speaking of talking to your providers, let's just finish up with thinking a little bit about communicating with your epilepsy team, because again, this is a joint effort, this is a conversation. So when something happens at home and you're calling in and you're talking with your epilepsy team, this is what we want to know. What did the seizure look like? If it was unwitnessed, what did you experience? And what's really important, we want to hear about the whole thing, but what's really important for us, especially if we're trying to figure out where seizures are coming from, is the very onset of the seizure, or even before the seizure felt like it was happening. What did you experience? Was there anything, even if it seems irrelevant, right? Did you feel any funny feelings? Did you smell anything? Did you hear anything? Did you see anything that was abnormal? Those can all be really important pieces. If you have a video of your seizure, we love to see seizure videos because it really helps us understand what you're describing to us. They're most helpful when they're well lit, so that, turning on the lights if it's overnight, where we can see the whole body, including the face, again, trying to localize that seizure if possible. And safety always comes first, so if a video is not available, that's totally fine. But if there are multiple people that are caring for the person having the seizure, this can be super helpful for your epilepsy team. We also always want to know what you're taking, again, because we might be thinking about changes. And even if you're not taking the doses that we prescribed, that's okay. We need to know that, right? We'd rather know that so we know how we can adjust things. Did you miss any recent doses? Again, we're not here to shame you. It's just going to help us with our changes. Any triggers that you can think of, and I've listed some common ones there. And I always want to emphasize that making changes is a joint discussion. So if you're calling in and you have thoughts on what's worked for you in the past or what you might want to consider, we want to know those thoughts. This is your body that we're talking about. We are here to make clinical recommendations, but we're working together to try and treat this. So please always let us know if you have thoughts about what you might think would be best for you next, okay? The other thing that I want to just throw in here is additional resources that we can provide. And so obviously we're talking a lot about next steps in treatment and things like that, but we know that epilepsy is more than just the next medicine, right, or the seizures. And so these are other things that we want to talk about, that you can ask about. Seizure action plans for school or work, accommodations, 504 plans, right? Assistance with additional care at home, support, transition from pediatric care to adult care. That can be a really tricky spot, and we have resources that we can provide and help you with that transition to make sure you have a seamless transition. Referrals to other subspecialties. We can talk about evidence-based references for further research. We know that there's a lot of information available on the internet, and we want to point you towards the resources that have the most evidence behind them so we can talk about that together. Connection to community resources and peer support groups, plug for Camp Discovery for our pediatric folks. But there's a lot of different resources available in our local communities and our national communities that we have connections to and we want to get you hooked into. That's something we really love to talk about. We can recommend to appropriate clinical research studies. I know specifically at Seattle Children's, we're always involved in multiple research studies that may be applicable for the person that you know with epilepsy or yourself. So always something to ask about. These are new things that are coming all the time. And also seizure first aid and rescue medicine teaching. These are things that we're always able to give a review on or to teach again. Or if it's a new rescue medicine, ask us for training and teaching. We want to make sure that you feel comfortable doing this at home. Okay? So I think with that, I've about hit my time. This is my dog, Flower. I have maybe just a few minutes for questions, but I'll wrap up there. Thank you.
I am wondering what you find most useful to hear from school nurses about.
Yes.
And secondly, a request that the seizure action plans indicate whether the seizure team believes the student has a life-threatening condition or not, to provide some guidance so that school nurses know whether that student needs to be excluded per the state law or not. Because there's, some nurses think, well, they've got a seizure rescue medication, it must be life-threatening, they can't come to school. So that would be incredibly helpful information. But like I said, beginning with what do you want to know from school nurses?
Yeah, that's a great point. And we're always adapting the language on our seizure action plans. I know specifically at Seattle Children's, we have, a format that meets all of the legal requirements, but knowing what you need at school is really helpful. And so that piece is really, really good to know. What we feel, the question was about school nurses and how their reports can help us. What we need to know is very similar to the things that I mentioned when you would call in. For lots of children, school is the place where they are the majority of the day, and so you may be seeing things, or their teachers may be seeing things that the parents aren't seeing at home. And so similarly to what I said before, if a child has an event, knowing the sequence of what happened, especially at the very beginning, if you can get any information from the kid about, what were you feeling right beforehand, what was happening, all those sorts of things. If you happen to know if they missed doses of their medicines. If this is something new, if you haven't seen this, if you're familiar with this child and you haven't seen them experience this type of episode before, that's something that's really important for us to know as well. And then, did you give rescue medicine? How did they respond to it? Those are really important things to know. But I think a lot of times what we hear is family is seeing something at home and the school team is seeing something at school, and those two things might be different. And so putting those two reports together can be really helpful in that clinical picture. So those are the things I think I would really focus on. But I hear your point about the seizure action plans, and I think where we can add that in is we have a list in our seizure action plan of descriptions of the different types of seizures, and we can say, in that description, this is something that could be life-threatening, if prolonged or something like that. So that's a really good note. Thank you. Did that answer your question? Okay, great. Anything else? I know I'm the first talk, so everyone's still warming up. Looks like we've got one over there.
Could you explain the temporal complex? It was up there on the slide. The sclerosis complex?
Oh, tuberous sclerosis complex? Yeah, absolutely. So tuberous sclerosis complex, or TSC, is a multisystemic genetic disorder that involves a mutation in what we call the mTOR pathway, and it's a pathway in the body that's responsible for a lot of different things surrounding growth. And so TSC is an overgrowth disorder. And so what we see is that we get overgrowths in different organs of the body, and that can include the brain. And so when we think about it in epilepsy context, it's a syndrome that can cause seizures. It can cause epilepsy and refractory epilepsy. We also see growths in the heart called rhabdomyomas, in the lungs, in the skin, and the eyes. So it's a multisystemic disorder. But at Seattle Children's, and I think in a lot of institutions, the kind of center for care is neurology because of the seizures and the epilepsy that can develop as part of that. And so it's one of those genetic diagnoses that we think about, right, when we're thinking about treatment, because we know that certain medicines work best in TSC versus other epilepsy syndromes. Again, that's one of my areas of specialty, so I'd be happy to talk about it more, but that's kind of how I think about it in the overview.
And then the second question is, what is the updated research on CBD for adults?
That's a great question. Like I said, I'm a pediatric specialist, and so I'm not the person that has the most up-to-date information on that, but I do know that we have a panel at the end of the day that'll have some adult epilepsy providers, and I encourage you to ask that question again so that you get the most accurate information. Yeah, absolutely.